Good day, I'm Jopassion Ipura, and we will discuss a case study in the Immunology, Serology, and Blood Banking. For the case background, a 40-year-old CG was seen by her family physician after several episodes of painless hematuria. On their questioning, she complained of worsening malaise and swelling of her legs and hands over the previous 2 weeks. She also reported that despite a high fluid intake, she was urinating much less frequently than normal. She had no significant medical history. On examination, the patient was pale and had generalized swelling of her extremities. Her temperature was 38.5 degrees Celsius, and her blood pressure was 160 over 110 millimeter of mercury. She had no palpable masses or hepatosplenomegaly. For the diagnosis, a diagnosis of idiopathic and rapidly progressive glomerulonephritis was made. The intervention she was given anti-hypertensive agents, corticosteroids, and azathioprine for 2 weeks. But her renal function deteriorated and an end-stage renal failure was diagnosed. Hemodialysis was initiated. In preparation for a possible renal transplant, she was tissue typed for MHC antigens using anti-HLA antibodies. She was found to be HLA A10, A228, B7, BW52, CW2, CW6, DR2, DRW10, and blood group B positive. A suitable cadaveric kidney was found from a donor of HLA A9, A28, B7, B17, CW2, CW6, DR2, DR4, and blood group B positive. Across much of the patient's serum with donor lymphocytes was satisfactory. She underwent a successful kidney transplantation. Her post-transplant treatment was a combined triple immunosuppressive regimen of prednisolone, cyclosporine A, and azathioprine. She progressed well immediately after transplant. 12 days after engraftment, the patient developed a fever and was noted to be lethargic. Physical examination revealed generalized edema. Her blood pressure was 165 over 110 millimeter of mercury. Her urine output had dropped significantly. A renal biopsy was performed. Histological examination demonstrated significant interstitial mononuclear cell infiltration. This finding was consistent with the diagnosis of acute graft rejection. She was immediately treated with parenteral methylprednisolone. This treatment failed to improve her renal function, and an anti-lymphocyte monoclonal antibody was administered. Her renal function improved, and she was eventually discharged, receiving cyclosporine A therapy. The questions and discussions. Question number 1. What factors are important in matching donor to recipient in renal transplantation? Question 2. How does this patient's graft rejection compare with other types of graft rejection? For question 1, what factors are important in matching donor recipient in renal transplantation? First is the histocompatibility or HLA matching. HLA or human leukocyte antigen are proteins that our body use to determine which cells belong to the body and which are foreign. HLA mismatch was the first donor factor to be identified that predicted mortality for transplant patients. Each mismatch decreases disease-free survival by 10%. The discovery led to the practice of using HLA and identical siblings for transplants rather than donors with HLA mismatch. The second factor is the blood group status. ABO blood group system is present not only on erythrocytes, but also on the vascular endothelium of the graft, making it necessary that transplants are performed only between A-B-O compatible pairs. Another factor is sensitization. Patients with alloantibodies must have had contact with foreign HLA antigens in one form or another. It is now well established that previously rejected allografts, pregnancies, pre-transplant blood transfusions, or infections are dominant causes of sensitization. Recipients with reactivity against a panel of lymphocytes from random individuals are categorized as positive for panel-resistant reactive antibodies and face delays for transplant even after a suitable donor has been found. Another factor is the patient age. Kidneys transplanted from younger donors or less than 40 years old generally have markedly superior survival rates as compared to those obtained from older donors, which are 40 years old and above. And higher graft failure has been reported when kidney donor is more than 60 years of age. It has also been argued that younger recipients with less than 30 years of age generally have a poorer long-term graft survival as compared to older recipients, possibly because of the fact that younger recipients are immunologically higher responders than older patients. Another is cross-matching. It is used to determine the presence of any preformed antibodies to donor antigens. The serum is also checked for autoantibody and whether or not the antibody is of IgM nature by absorbing the recipient serum with dithiotreator or DTT. The cross-match procedure is always repeated one day prior to transplantation so as to detect any new sensitization due to blood transfusions. It is generally agreed that a positive cross-match against T cells is a definitive contraindication for a renal transplantation. However, transplants made in the presence of B-cold or T and B-cold antibodies or autoantibodies are not rejected and may even show enhancement, while the presence of T and B worm antibodies at 37 degrees Celsius may not be good for the graft. The recognition of these different antibodies have allowed a number of highly sensitized patients to be transplanted, which otherwise would have remained untransplanted. Another factor is the donors in retransplantation. Success rate for renal retransplantation have consistently lagged behind those of first transplants. Sensitization associated with the loss of a transplanted kidney is generally regarded as a major obstacle to retransplantation. It is now generally agreed that patients requiring a second transplant should have a better matched donor, as it is associated with decreased degree of sensitization, and thus possibilities of enhanced graft survival. The second donor should preferably not carry the same mismatched HLA antigen as of the previous donor. This avoids the boosting of sensitization. Question number 2. What factors are important in matching donor to recipient in renal transplantation? Another factor is the transplantation delay. In general, patients who are transplanted shortly after diagnosis fare better than those who are transplanted a long time after diagnosis. A decision analysis in MDS based on cumulative data from the International Bone Marrow Transplant Registry or IBMTR and other sources showed that patients with low risk or intermediate 1 disease did better when transplanted at the time of disease progression rather than at the time of diagnosis. However, transplantation at a fixed interval after diagnosis, but before the formation of the AML, maximized overall discounted life expectancy. These are the references for the course. How does this patient's graft rejection compare with other types of graft rejection? The patient shows an acute type of graft rejection, which occurs days to months after a transplantation, when the immune system identifies a grafted organ as foreign and attacks it. It has been associated with increased expression of HLA class 1 and class 2 antigens in inflamed grafts, and with early infiltration of CD8 T cells. Histologically, there's a mononuclear infiltrate in the renal cortex and necrosis of arterial walls. After successful treatment, the inflammatory infiltrate clears. The diagnosis of acute rejection is based on clinical data, including the patient's symptoms and signs, and confirmed by laboratory studies of blood and a tissue biopsy, wherein in this case, the patient experienced general edema, high blood pressure, and anuria. The graft rejection is confirmed by renal biopsy that shows significant interstitial mononuclear cell infiltration. That's it. Thank you for listening.